Good afternoon, everybody. I'm pleased to welcome you to the annual general meeting of Berkshire Healthcare NHS Foundation Trust. This is the second year we have run our AGM online. I hope you find it easy to use. The reason we showed the first slide was so that you could see particularly where to submit your questions through the Q&A function. So if you look at the top bar of your Teams Live screen, you'll see two speech bubbles. You can submit your questions at any point during the presentations, and I will be looking at those and taking those to our panel of speakers for you. So if we can go to the agenda, please. I'll soon be handing over to Martin Earwicker, our chair, to welcome you all and to update on the work of the governors. We'll have our usual sections from Julian Emms, our chief executive, in terms of a review of 2021, and Paul Gray, our chief financial officer, will be updating on the financial results for the year also. There will be opportunities to do questions on those presentations, as there will be for our two service presentations from Neuro Rehabilitation Services and our children and adolescent mental health services. So really looking forward to seeing and hearing from our colleagues today, particular highlights there. And Martin will close the meeting. I'm now going to introduce Martin to open and welcome you all to the AGM. Thank you, Martin.
Well, thank you very much, Alex, and may I just add my welcome to everyone who's joined us today. We're delighted that you're able to, and I hope you'll find something interesting during the presentations. Although I'm chair of the NHS Trust, I also have another role, which is chair of the Council of Governors, who play an important part in the Trust. And I just want to give a report of the activity of the governors during the last year. Next slide, please. So our governors are appointed by a range of processes. There are public elected governors, those in the green at the top left of this slide, who are elected by our members, the members of the Trust. There are staff elected governors in the top right of the slide, who are elected by staff. And then at the bottom of the slide shows the appointed governors. These are governors appointed largely from our local authorities that we serve, but also from some of the other institutions that we have close relationships with. Next slide, please. The Council of Governors, which is the formal meeting, is held 4 times a year to conduct formal business. We've been running meetings online since the start of the COVID-19 pandemic, and it's actually been working pretty well. We also have informal meetings of governors with our executive and non-executive director colleagues, which gives an opportunity for governors to get involved in more questioning of the Trust and the Trust board. The sort of areas governors focus on are patient safety, service quality, and financial sustainability. Next slide, please. So during 2021, the governors have focused on a whole range of activities, which are shown in this slide, ranging from strategic issues to do with the development of integrated care systems, COVID-19, of course, people, support for our veterans, our staff, and the recovery plan. And you can see the other things as well. And the governors choose the topics they want to hear about, and that gives them a chance to interact and to question the Trust on its performance. Next slide, please. The governors also have some formal roles, one of which is to appoint the external auditors of the Trust, and that gives a degree of independence, so the Council of Governors can be convinced that the auditors are acting on their behalf and they report to the governors. And in fact, this morning we had a report from the external auditors on the Trust for the last year. Next slide. And the governors also appoint the non-executive directors on the board, and indeed the chair. And we appointed, or the governors reappointed Naomi Coxwell for a second term as a non-executive director. And we run a campaign to replace Chris Fisher, who currently is a non-executive director who chairs the audit committee, but he retires from the board on the 30th of September. and we have a new candidate, Rajiv Gatha, who's going to be taking over from the 1st of October. Next slide, please. The council also has some subgroups to enable governors to get involved in certain topics in more detail. The Quality Assurance Group, which does what it says and reviews the quality of care we provide to our patients. The Membership and Engagement Group, which is about increasing the numbers of members, increasing the diversity of our members, and also engaging with the public. And then Living Life to the Full Group, which is very much about helping people live their lives to the full beyond diagnosis, and is a really valuable part of our governor's role. Next slide, please. We very much welcome the involvement of the public in the trust. If you want to become a governor, please email Julie Hill, our company secretary, at the bottom, and we really do welcome inputs from people from all sorts of backgrounds, young and old, from all sorts of ethnic backgrounds. So please do get in touch if you're interested. Thank you very much.
Thank you, Martin. So we will now hand over to Julian Emms, our Chief Executive, to update on the activities in the Trust and in the last year, and with a bit of a forward look. Thank you, Julian.
Yeah, thank you very much. So this is a review of the last financial year, so April 2020 to the end of March 2021. So it is a bit of a look back. And those dates will obviously resonate with us all, because obviously it was at the height of the pandemic. And so perhaps inevitably the things I talk about are perhaps more touched by that. We did a heck of a lot of other things during this period. And if you do want to know more about the activity of the Trust during those 12 months, I can suggest you read the whole of the report, which is obviously very detailed, but also the quality account too. So these are just my selected highlights. So if we can have the next slide, please. It's fair to say that some people do get confused by different providers and commissioners in the NHS. And just to say, Berkshire Healthcare, we're the main provider of community mental health services across Berkshire. We have an income of actually about 280 million now, and we employ just over 4,500 staff over 98 sites. And we are, in terms of our makeup, we are 50-50 in terms of mental health and community physical health, and we also provide some GP services out of hours. We're a combined trust, and obviously we work very closely with our partners in two integrated care systems, which is about collaboration. One is called Bob, Berkshire, West Oxfordshire and Buckinghamshire, and the other Frimley, and essentially that is a collaboration of the NHS, whether they be Royal Berkshire, Frimley Health, colleagues in Buckinghamshire, and of course local authority colleagues in the voluntary sector. And it's really about doing good and making a difference rather than competing. It's about collaboration. If I can have the next slide, please. There might be a bit of a delay, I think, on the slides today. And just to say, just as we went into this financial year, we were absolutely thrilled, delighted to be awarded outstanding by the CQC. We've got a good track record with them, as the slide tells you. We've never been rated anything less than good. And for our well-led element, we've been outstanding for some time now. So to get an overall outstanding for our clinical services as we get into the pandemic was a real boost for us. It put us in a great shape. And 4 of our services, as you can see, are now rated outstanding overall: community physical health services for adults, end-of-life services, learning disability inpatients, and our older people's mental health, community mental health services. And all our other services are rated good or outstanding. Despite being immensely proud by that, there is not a member of staff in Berkshire Healthcare, an exec director or a board member, who is at all complacent, who thinks we're perfect. The reverse is the truth. We think that actually this is a fantastic building block on which to further progress and make improvements during the next few years, and that is our intention. It also put us in a good place, as I said, for the pandemic, more of which now we can talk about on the next slide. So as you can imagine, the last sort of year that we're looking at was like no other. And it is absolutely fair to say, and we should recognise this, that it absolutely brought the very best out in our colleagues. And I want to take this opportunity on record to say a huge thank you to all of our staff. That's all of our staff. So, of course, some of our clinicians did some amazing things directly with our patients, but non-clinical staff gave everything also this year, and that's very important to say. So just think about the important work our cleaners and domestics did in terms of making sure infection prevention and control measures were in place. So everybody did a remarkable job, and we asked a lot of people. So quite a number of our colleagues, over 200 or so in community services, their services were suspended in the early days of this pandemic, and staff redeployed to services which continue to operate. As an example, we had school nurses working out of inpatient areas looking after end-of-life patients, which would be completely new to them for the very first time. So people were put in some quite difficult and demanding situations that they'd never been in before, and did a remarkable job. And that dedication, hard work and resilience has been truly remarkable, and a year as a consequence that I shall never ever forget. Next slide, please. It has been really important, and I suppose one of the key things that we really homed in on is keeping our patients safe this year. That has been a real focus, keeping everyone safe. So naturally, there's been a huge emphasis, and there continues to be huge emphasis on following national infection prevention and control guidance rigorously. So Dr. Minu Arani, our Chief Medical Officer, and Debbie Fulton, our Director of Nursing and Therapies, have been absolutely instrumental in making sure that we do everything we can. And of course, this guidance has changed as the time has gone on, but making sure staff are wearing appropriate PPE to keep everybody safe. We've adapted our services where appropriate, and you can see that through the fact that we've had a huge expansion of online appointments. So we were doing about 300 a month before the pandemic, and that was quite advanced. That was one of the leading trusts in the country. It's now steady around 8,000 a month. And during the last 12 months of the year under review, we were awarded Global Digital Exemplar status, the only community and mental health trust in the country to be actually complete that programme of work. And in a nutshell, it is for our all-round level of digitalisation in the organisation. But again, it shows that we were pretty well prepared for that online consultation and those other changes. And our ability to utilise technology has helped to safeguard our patients. So some of the patients who haven't wanted to come to our buildings have been able to do that remotely. And it's also safeguarded our staff by allowing those who can to be able to work from home. Next slide, please. One of the key defences we've had for the pandemic, for coronavirus, has been the vaccination programme. And in December 2020, Berkshire Healthcare was selected to support the rollout of the national COVID-19 vaccination programme. So the very early days of vaccination when it first happened. Our team were absolutely amazing, as were all the volunteers who contributed to our vaccine hub. And they administered over 36,000 doses of vaccine, not just to our staff, but mainly to staff working in health and social care. So that includes staff working in care homes, for example, staff working in children's services in our local authorities, as an example. What a remarkable thing that was. And they didn't only just roll out those numbers, the process and the system around our vaccination was slick, effective, and very well run. Next slide, please. I talked early on, didn't I, about the integrated care systems, and one of the things that's been a joy during the pandemic has been really to make a difference for patients by joining up care during the pandemic. There's lots of examples of that, and you're going to hear from some clinical examples in more detail a little later on, so I won't steal their limelight. But one example has been the Rapid Community Discharge Service that was established with between the NHS and local councils. And really, in a nutshell, that was to speed up and facilitate the timely discharge from hospital and ensure hospitals did not become overwhelmed, particularly in those early phases. And the philosophy was very straightforward, which is we should try and get patients home as quickly as possible, because we know actually the longer time patients spend in hospital, the less quick their rehabilitation is, and often that is severely compromised. And we were able to do that at pace. 90% of patients actually who went through the rapid community discharge programme ended up going directly home as opposed to nursing homes or other supported living arrangements. The rapid community discharge service operates 7 days a week, and highlights include expanded discharge teams, simplified funding for onward care. So if a patient was determined to be able to go to a particular place, then the funding was sorted out afterwards and they went to that placement first. Dedicated 7-day-a-week transport, and we started to see intensive therapy on the wards, things like physiotherapy, speech and language therapy, occupational therapy, actually happening intensely on our community wards 7 days a week. And at the same time, we were able to reduce the number of delayed transfers of care on our mental health wards from 7% to just over 4%. So I'm really making a difference for patients, which has been fabulous. Next slide, please. And so, as you can imagine, and it is inevitable that even in the early days, but particularly now as the pandemic has gone on, there has been a terrific strain on our people. Some people have witnessed trauma, others in the early days took very little rest, and supporting the well-being of our staff has been absolute paramount, not just our own staff, but our colleagues working in other parts of the NHS and social care. And as a key component of that, we've established a dedicated psychological staff support service. So in addition to all the other things we do, a top of the range dedicated psychological staff support service for individuals or for teams. And that's been really important, not only for ourselves, but as I say, for other NHS organisations and social care staff. This year, in the NHS staff survey, we came top in the sector for staff engagement. So that's measured by satisfaction, motivation and pride in the organisation. So there are questions about whether you would recommend Berkshire Healthcare as a place to work, or recommend Berkshire Healthcare to family and friends as a place to get treatment. And overall, combined, we came top, and we were absolutely delighted with that, particularly during those difficult times. However, looking forward, when we drill down into that, the organisation still has much to do. So actually the results with regard to race, ethnicity, disability and sexual orientation were much less encouraging, and that's been the case for a while. So our focus, particularly with our people, has been to address those factors and really start to make a difference. And if you read the annual report, you'll see something around our targets and our aspirations to really make a difference for those particular groups of staff. We think it's actually mission critical and one of our #1 priorities if we are truly to be an exceptional organisation for all of our people and for all of our patients. Next slide, please. And the thing that I shall remember probably, and that has really stood out, was the huge amount of support that we had from the public, communities, businesses and individuals. It really was at times quite overwhelming. The message of support, the compassion, the generosity, the donations, all added up to be a really, really heartfelt thank you from the community. And I don't think Berkshire Healthcare has ever felt better connected to the community that it serves. It really, really did make a difference. So if you were one of those that contributed in any way, it might have been a nice message. It may have been a donation of some kind. You may have been one of those individuals who cooked food and brought it into one of our hospitals. I thank you, and the board thank you, because it made such a difference. It really did. And to be connected like that is absolutely fabulous. So that is a whistle-stop tour of some of the things we did during the course of the year. Very happy to take any questions. But before I do that, we have a statutory responsibility just to report on the financial position of the organisation during 2020 to 2021. I'm going to hand over to my colleague, Paul Gray, who's the Acting Chief Finance Officer. Thanks, Paul.
Thank you, Julian. Going to take the first slide, please. Just delayed, but thank you. So, as you can imagine, as Julian has articulated, COVID has impacted the organisation and all of our lives, and the financial regime that the organisation has operated on over the past year has been adapted and is effectively bespoke in response to that COVID pandemic. So the normal annual planning cycle that the organisation would have undertaken was suspended in March 2020 and was replaced by a regime that meant that the organisation could focus its staff and its resources in responding to the pandemic. So to that end, over the past year, we've seen a central commitment that all of the additional costs that we incurred arising from our response to the pandemic were to be met. In addition to that, to ensure that the finances of NHS provider organisations were secure, we received further funding enabling us to achieve a minimum of a break-even position during the year. Our obvious use of PPE has been far in excess of what it would have been in a normal year, and we've benefited from that being centrally procured and centrally funded over the past year. And to ensure that organisations didn't face any liquidity issues, the timing of contract payments from our commissioners were brought forward so that all organisations had sufficient cash to meet the challenges. And the normal efficiency programmes that we would run on an annual basis, certainly for 2021, were suspended again, allowing us to put resources where we needed them over that year. If I could just get the next slide, please. So if we move on to the financial performance for 2021, at a bottom line, we delivered a £900,000 surplus for the year, which is in line with the financial results from 1920. You'll see that in terms of income and expenditure, we saw quite substantial increases of over 25 million in both revenue and cost. Within that 25 million are the costs and the funding that we received in terms of our pandemic response. And if we can just go into those in a bit more detail. So an additional 10.5 million of marginal costs incurred responding to the pandemic. So that's costs over and above what we would have seen in a normal year. And those would have gone on additional costs for staff covering sickness and doing additional shifts, purchase of additional equipment, adaptation to our buildings to respond to social distancing requirements and increased infection prevention control measures, and also equipping and making sure that we could provide adequate resources to enable a great many of our staff to work from home during the pandemic and keep them safe. And in addition to that, 2.2 million of centrally funded PPE, which is around 2 million more than we would see in a normal year. The remainder of that, those 25 million increases, are normal annual inflation increases, as well as ongoing commitment from commissioners in terms of investments into our services, so mental health investment and community investment. Despite all the challenges of the past year, we maintained our capital investment programme and we invested 8.5 million over the course of the year in a range of IT equipment and infrastructure costs, as well as maintaining improvements in our estate, with some key developments around the movement of learning disabilities to our Prospect Park Hospital and completion of our early house development on the Reading University campus. We saw cash increase by 12.7 million to 39 million by the end of the year. And I think what was pleasing was, given all of the issues that we faced and changes to the financial regime, we finished the year with an unqualified audit opinion from Deloitte, our external auditors, which means that effectively there were no material errors or adjustments that were required to our accounts. If I could just take the next slide, please. So looking forward, so in the current year 21-22, we're still operating under a financial regime. We won't go back to normal financial planning probably till 22-23. So we've submitted a break-even plan for the first half of this year, and we're on course to deliver that. We are still in receipt of additional funding from the centre to support costs that are ongoing in terms of our response to the COVID pandemic. And since the beginning of the year, we have got additional funding coming through our funding settlement to try and address some of the services where we've seen waits increase over the past year. And again, we're continuing to plan to invest in our estate and our infrastructure, and for 21-22 we're planning to spend another 7.9 million in capital expenditure during the course of the year. We're in the throes at the moment of planning for the second half of 21-22 and expect that we'll be planning to break even by the end of this year, with continued funding from the centre, albeit probably at a slightly reduced level. Thank you.
Julian and Paul, thank you very much for that year in review. And as Julian said, memorable for all sorts of reasons, and some fantastic highlights of what we've been able to achieve nonetheless, alongside responding to the COVID pandemic. Really looking forward to our service presentations coming up in a second. I've got 3 questions, actually 2 questions and a comment. So let's go to those. So thank you, Nicholas Welch. No mention of children's mental health services, which has a 2-year waiting list and now has been surpassed. How is this poor state of affairs going to be remedied? And Julian, can I ask you to respond to that, please?
Yeah, thanks, Nicholas. Yeah, it's a very good point. The waiting list for children particularly is around neurodiversity, so it's ADHD and ASD assessments, which actually has been a long-standing problem for us and the country due to sort of chronic underinvestment and a significant rise in demand. And the waits are unacceptable. They're unacceptable before the pandemic, and the pandemic certainly hasn't helped. And we have worked hard to raise the profile of this, and we have received some additional income from the clinical commissioning groups, who effectively commissioners or provide us with the money to do that, right across the county, which should see a halving at least of that waiting time in the next 12 to 18 months. The issue that's slowing things down is there's actually a shortage of the workforce. So having the money is one thing, but recruiting the workforce is certainly a challenge. But we have been able to utilise the private sector to be able to do some of the less complex assessments, particularly online, and they have picked up quite a lot of that work. So I agree, unacceptable amount of waits. It bothers us. We've managed to get some additional resource. I don't think there's a magic kind of wand that will see that waits reduced quickly, and it's the biggest source of inquiries that I get. But we do have a plan, and we do have some investment now to be able to start tackling it, and we are seeing and working through that waiting list at a rate that we've never been able to before. But it is big, and the other thing is we've seen the demand for those assessments double in the last 5 years, which is pretty unprecedented. And the Thames Valley, for unknown reasons, has the highest level of demand for those assessments, so way beyond what I might think of the population. So very good, fair question. I hope that gives you some sense around the fact that it is a priority here.
Thanks, Julian. Just continuing the theme around CAMHS, Tony Lloyd has asked, are there any plans to make significant improvements to the CAMHS service in Berkshire West? You've answered that. But specifically, was this service looked at by the CQC in the last round?
It was in depth, Tony. And so the bit, obviously there's lots of bits to child and adolescent mental health services, and some of those are actually very responsive. So our crisis service sees people immediately. We've got now a day hospital service, and waits for things like anxiety and depression are relatively short, certainly within a school term. It really is the ADHD and ASD assessments that are taking a long time. The CQC's assessment of our services were they were safe, effective, well led, but they weren't as responsive as they could be for CAMHS. However, the CQC recognised that this wasn't an issue entirely in the gift of the trust to fix, and it asked and implored commissioners, the CCG, and local authorities also to play their part, and that was quite helpful in terms of securing the additional funding. So yes, they rated CAMHS good overall. They acknowledged, as I have done, the waits in ASD and ADHD, which they're seeing nationally, and recognised there needed to be a system-wide response to that, which we have now got.
Thanks, Julian. And another question from Nicholas Welch on the wider support from GP services. At what point will GP services return to 80% face-to-face appointments?
Sorry, Alex, at what point will GP services?
Yeah, GP services.
Yeah, so I can't answer that question because the daytime primary care services GPs we don't run. What I can say is, because I obviously meet with primary care, is that they are very much looking to get that balance right. And I don't think there's a figure about 80 or 20 or whatever. What they're looking to do is make sure they get the right appointment for the right condition and the right person, really. And as you know, there's been quite a lot of concern and emphasis on this in the media in the last week or two. Primary care is seeing more patients than they were prior to the pandemic, but that's partly because obviously they're able to do some virtually, some via telephone and some face-to-face. I expect there will be a shift in due course in terms of that, but I don't know if it'll be 80-20, but ultimately I suspect the CCG and the GPs themselves will be probably the best people who can give you the most up-to-date assessment. But that's the conversation that I've been having them when I've been in those meetings, but not running daytime GP services. We're just going to be a bit cautious. We're not speaking on behalf of others.
Thanks, Julian. And I've got a question here from Yvonne Olney. Thank you, Yvonne. How is the Trust dealing with the shortage of staff, particularly physiotherapy? Is there a plan to recruit and train internally to future-proof this shortage? Many thanks. And Julian, if you're okay, I can pick up the first start to the answer as lead in the Trust for People and HR. And I should have introduced myself. My name's Alex Guild. I'm Deputy Chief Executive at the Trust. So we are clear that our retention of our workforce, so when people join us, we develop and create a very clear career pathway for them, is absolutely critical given the supply shortage of workforce right across the board, including physiotherapy. And so taking a much more creative and innovative approach to developing and communicating a career pathway for our therapists is going to be key to the future around our workforce risks. And that can be around creating new specialist roles within the Trust. Often therapists will get to a certain point and a certain banding of salary and can't go beyond because there aren't any other roles available, and they will move from the Trust. So we are looking very carefully about how we can improve retention with a really clear career pathway. Julian, did you want to add anything else to that, specifically around physio or wider?
No, I think the other thing that I've seen, and I've had some good conversations internally with physio, in addition to all the things you've mentioned, I think the one thing that was most impressive for me was about career opportunities. So I spent some time with the community specialist service, where there's an opportunity to continue to practice clinically at 8A or 8B, and that in terms of agenda for change. So for those people who are not familiar with that, that's senior sort of clinical posts, and they have posts where there's quite a lot of autonomy. And the interesting thing about that was a new service that perhaps traditionally, where patients might traditionally have been seen in hospital around particular issues around knees, joints, hips, but the first point of referral is to our community specialist service. So I think if we're able to develop some more specialist service, what we're able to see is that actually there's better career pathways for people, so which also I think will help with retention. So I don't think there's one answer to that particular question, but I think it will be doing all of those things well, which will help.
Thank you. And then before we move on to our service presentations, we've just got a really helpful comment here. Thank you. How about assigning independent, unbiased caseworkers to aid in the translation or interpreting, independent from family members of patient or hospital staff? I have experience working with non-native speakers within Berkshire County, and there were clear issues with mental health due to COVID or the state of patients, refugees. And we've got your contact details there, and absolutely critical that we're able to communicate well with all of our patients wherever they live, work and are from, and translation services are critical to effective care delivery. So thank you for making that point.
Alex, and just to say, Alex, we do have interpretation and translation service on a contract for that to be able to do that, but if the individual feels there's a gap or a seen a gap, I know Kathy Saunders our head of communications has taken details as well, so we can just check in to make sure that perhaps there's nothing sort of that someone's picked up about the service we currently have that could be improved upon.
Thanks, Julian. Great questions, thank you. And if you have more, please do submit them through. We will have some time at the end. Really pleased now to introduce the first segment in our clinical service presentations, and I'm going to welcome Lisa, who is from the Neuro Rehabilitation Service. And we've talked about how the Trust has responded to COVID. Well, many of our services, including this one, have had to respond and change the way they work, whilst maintaining a wonderful impact on the people that they are caring for. And I think we're going to see some of that come through in Lisa's presentation. And it's welcome to you, Lisa.
Thank you. So I'm Lisa Rowson. I'm one of the occupational therapists in the community-based Neuro Rehab team. I'm actually just standing in for Lisa Ellis today. So I'm going to tell you a little bit about our service and how we've adapted during the pandemic to meet the needs of our patients. Could I have the first slide, please? Okay, so just some statistics. So in the UK, stroke is the leading cause of death and disability in adults. 1 in 6 will have a stroke in their lifetime, and there are currently over 1.2 million stroke survivors in the UK. 2 in 3 stroke survivors will leave hospital with a disability, and that's estimated to cost health and social care around £26 billion per year. So the average age of somebody having a stroke is decreasing. So 1 in 3 people are aged between 40 and 69, and that's certainly something that we've seen with our caseload at the minute. So 52% of our active patients are working age. So NICE have predicted that by 2035, stroke survivors living with a disability in the UK will increase by 1/3, and that's possibly due to the advances in acute treatment of stroke. We see more patients now that have had thrombolysis or they've undergone thrombectomy, resulting in better clinical outcomes, but still the cause of disability. So in 2013, NICE produced guidance on stroke rehabilitation in adults with a view to improve rehabilitation, and it gave detailed recommendations on assessments and interventions. When the quality standard on stroke was updated in 2016, it shifted the focus from acute care to rehabilitation, which reflected the increasing number of patients that were surviving having a stroke. Next slide, please. So these are just some statistics for our service. So our service started in 2008, and we were initially commissioned to take 325 referrals per year, but you'll see sort of year on year that the referral number has increased, and it continues to do so at quite a rapid rate. Next slide, please. So early supported discharge of stroke patients is the continuation of rehabilitation at home, and the intention is that the patients will receive the same intensity of inputs that they've received on an acute stroke unit, and also they'll receive the input from staff that have the same level of expertise as well that they would have seen in hospital. NICE guidelines recommend early supported discharge as well. SNAP estimates that 34% of stroke survivors are suitable for ESD. So in the last 5 years, there's been an increase in the proportion of people receiving ESD. So you can see that in 2013 to 14, it was 25% of patients having a stroke, and that increased to 36% in 2017 to 18, and it continues to rise. We've also noticed as well, looking at length of stay in the acute stroke units, that we are reducing that length of stay by taking patients out on our early supported discharge team. So vocational rehab So after a stroke, many adults will still have significant disabilities that prevent them from returning to work. And that certainly fits with the demographics of our patients being quite young at the minute and of working age. So that can have a huge impact on a whole array of areas of somebody's life. It can change their role and their identity, a perceived status, a change in their status, and then the obvious financial implications, a change in their quality of life. NICE recommends that adults who have had a stroke are offered active management to return to work if they do so, but in 2015 only 27% of CCGs commissioned vocational rehab services. That's something that we're currently auditing ourselves within the community-based neuro rehab team, and the number of patients and the outcomes that we're seeing following vocational rehab that we offer. Next slide, please. So our service is made up of clinical specialists that all specialise in the treatment of neurological conditions. So within our service, we have got clinical neuropsychologists, occupational therapists, physiotherapists, speech and language therapists. We've got specialist stroke rehab nurses, therapy assistants that work across all of the disciplines. We've got a fantastic admin team, and our service manager, Lisa, has got clinical expertise. Her background is physiotherapy. So we treat all neurological conditions. I would say that we get the most referrals for stroke, followed by multiple sclerosis and then head injuries, but we also treat spinal patients, Guillain-Barré, functional neurological disorders, and we treat the rare neurological disorders as well, so conditions like motor neurone disease and progressive supranuclear palsy, those rarer conditions. So the service itself is split into different components. Across East and West Berkshire, we have the early supported discharge service. We also cover 8 neuro beds at West Berkshire Community Hospital, and then the community-based neuro rehab team, which is just in West Berkshire. We have stroke reviews as well that are completed at 6 months by our stroke nurses. Next slide, please. So access to timely and specialist rehab is key in achieving meaningful outcomes for our patients. There's a whole array of outcomes that we do achieve. We look at driving. We've got driving assessment batteries that we can use, and we also refer on to Regional Driving Assessment Centre. We complete cognitive assessments, and that might be in function, and we've also got a range of formal cognitive assessment batteries that we use. We promote independence physically, mentally and emotionally. Our speech and language therapists look at swallowing and communication impairments. We offer fatigue management, assessment of executive functioning. We offer lots of education programs as well, and focus on empowering our patients. Our physios do lots of work with gaits and balance re-education, accessing the community, and then we liaise with lots of other services like orthotics, wheelchair services, and postural management services. Next slide, please. So how have we adapted during COVID? So we've used lots of digital remote appointments. We've focused on a self-management approach for our patients as well, and we have developed a face-to-face decision-making tool which contains a risk assessment, so that enabled us to reduce the risk of seeing the patients that were more clinically vulnerable and offer them alternatives, and it just helped us sort of work through our clinical reasoning of when we should be seeing people face to face versus remote. We have done some joint work with the Oxford Health Science Network, and we had a working group with them, and they've allowed us to look at the effectiveness of our remote appointments and how to focus on those a little bit more. Next slide, please. So we focus on empowering our patients, and our goals are always patient-centred and patient-led. We complete, again, lots of education, enabling patients to understand their condition and can complete their own management where possible. A graded approach to increasing quality of life. We also work a lot with different charities and other organisations such as the Stroke Association and Headway. We take a holistic approach. We do lots of shared learning across our disciplines, that's sort of formally and informally. So, for example, in team meetings, our stroke nurses might provide us with in-services about BP monitoring or secondary prevention or medication management in stroke. And then we're inclusive of family members as well, and our psychologists will often support our carers as well as the patients. Next slide, please. So the National Stroke Network, we have a fortnightly call with all the community stroke services nationally, and this allows us to support each other. We can share resources and clinical expertise, and it's allowed us to brainstorm best practice during COVID, and we've got links with some of the specialist stroke consultants. Next slide, please. And then this is just a slide that demonstrates some of the projects that we've worked on with the Oxford Academic and Health Science Network, and looking at some of the focuses of maximising use of groups remotely, and allocating sort of face-to-face sessions and completing virtual education groups. So that's been led by them. Next slide, please. So I think we've got a case study now and a video, and then I'll answer any questions.
Thank you for doing this. So if it's all right, Gavin, can you just tell us a little bit about what your rehab experience was like?
So about 4 days in from my stroke when I moved down to West Berks, and at that point I think they just about got me out of the bed, so I could just about stand with the prop. Couldn't really walk at all. My right arm was pretty useless, so it wasn't moving at all. So I was, trying to eat with my left hand was becoming quite an interesting thing. I think, yeah, it was interesting as well because I'd only, looking back, I did all the swallow tests that we do as well, but I did them before I actually really had the full extent of the stroke. Mm-hmm. So unbeknown to everybody, I actually had to learn the swallow bit as well before things started. So yeah, I think when I started, I had no use of my right leg, very limited use of the right leg. I could just about stand on it, and no use at all of my right arm.
Yeah, okey-doke. And how did the therapy sessions go? Did you sort of feel quite involved with things?
They were, as a team, everybody actually got involved with me. I mean, I know we had the sort of formal goal setting, but also it didn't feel like I was being told to do something. It was, everybody explained what we're trying to get out of each exercise, and kind of involved me in what we were actually trying to do. So it was, I felt everything we did was tailored to me rather than following a prescribed set of routine.
Were there sort of particular things that you found really helpful or that worked really well?
I thought the fact that as a team, you kind of really reached out and saw what I needed and arranged for things, you know, working with the other physio departments, being able to get downstairs, use the equipment. I found that was really, you know, particularly as I got stronger, that was really, really useful because it allowed me to push on. And I think it was a really good example of how, as a whole team, you were working together. Because I don't, you know, particularly around COVID, I don't know how normal that is in your working, but it was something that I felt worked really well. Just you know, one, it got me out of the environment just being upstairs, but two, it then gave me, you know, gave us a chance to push on and try different things.
We used the outpatient gym, didn't we, at one time to get to the treadmill and exercise bike and things. Yeah.
And then we also used the inpatient, the gym downstairs. So Vicky and I went down there and used that one as well to try some of the facilities down there.
Yeah. And anything that you think, you know, we could improve as a service? Anything that you?
I think the hard bit is it seemed to be, and I know you did get around some of it, but it being all the equipment being owned by different teams meant it was quite hard if you wanted to say, I think at one stage we were trying to try some little dumbbell weights, which we didn't have upstairs. So I was using them in the outpatients gym, but of course they had to stay there. They couldn't come up and then were worked on later. So if we could, if there was a better way of and I know it's difficult because you don't want to, someone doesn't want to find that they're needing to use it at patient and it's gone. But a better way of working around so that more stuff can be pulled around. Right.
Yeah. Okay. And also maybe just tell us a little bit about where you are now then.
So I progressed, carried on progressing since I came home from the hospital. Worked through and did a lot of stuff. Especially I used the FES type technology, and that really helped improve my walking through Odd-Stop. And I went walk. Yeah, basically got walking up. I got my ability to get back on a bicycle and running up until the point where I was able to do a triathlon and get back into it. It's funny, I actually just recently wrote to British Triathlon to see whether I actually qualify under the para triathlon and actually maybe do some competitions next year under that. So
brilliant.
Haven't heard back from them yet. So.
Okay, that's great. Thank you very much.
Lisa, thank you very much for your presentation and really well done for standing in the essence of the service, the multidisciplinary team wrapping around supporting the community and hearing from the patient himself about the effects. It was really powerful. So thank you very much indeed. And you've got some really good comments here from members of the public about your presentation. I've got one specific question from Tony Lloyd. Recent research has shown evidence that neuroplasticity after a stroke is retained for up to 3 months. Does the current physio regime for stroke patients take full advantage of this window? Are you able to answer that question?
I am, and he's quite correct. So our early supported discharge team, we see patients straight away, that we take them out of the acute, so there's that continuation of treatment. We're able to see them for 6 weeks. For that period, and then we've also got our community-based neuro rehab team that they can be referred on to for further treatment if they've got outstanding rehabilitation goals. So we do take advantage of the neuroplasticity in the early period, and we also provide training and education so that the patients can continue with the rehabilitation themselves.
Fantastic, thank you. A question here. Many thanks, Lisa. What a fantastic service. Can you tell me if there are any plans to expand your full services to the patients of East Berkshire? Which may not be a fair question for you yourself, but I just wondered if you had a view about service provision across Berkshire, and we could bring in Jane Reynolds in a second around provision in East Berkshire.
Yeah, so East Berkshire has the early supported discharge team for stroke, which runs for 6 weeks, but it doesn't have the community-based neuro rehab team for all of the neurological conditions. And I know this is something that my service manager, Lisa Ellis, has looked at. She's looked at the provision across East and West Berkshire, and I think that's a bit of an ongoing project.
Thanks, Lisa. Jane, did you want to come in around that?
Not really much more to add to that, Lisa, but yeah, it is a piece of work that's being looked at across the system and making sure that Frimley ICS is consistent in terms of its stroke offer and its neuro rehab offer. Certainly a lot to learn from the West and to roll that out.
Thank you. Brilliant, Lisa, and you can see the comments here appreciating your presentation. Thank you very much indeed. I am conscious of time. We've got a running order until 3:15, and we now welcome Louise Noble, who's going to talk us through an innovative new service model that avoids the need for admission to children's inpatient services. Welcome, Louise.
Thanks, Alex. Yep, so I'm going to talk you through a project that we've been running over the last few months, developing an alternative to our inpatient service. If I could have the next slide, please. So just to give you a little bit of background, we've run an inpatient service at Wilow House, which is on the Wokingham hospital site, for children and young people since 2015. We've run a service that was a general adolescent inpatient unit. CAMHS inpatient care is quite a small niche service. We have between 50 and 60 young people in Berkshire every year who need inpatient care. About half of those need general adolescent inpatient care. The other half need more specialist care, such as psychiatric intensive care, or secure types of care, or even specialist eating disorders care, which we historically didn't provide at Wilow House. The service was set up and commissioned by NHS England. It was a service that was available to support young people nationally from anywhere in the country. So while we worked very hard to make sure that our Berkshire population were able to be admitted to Wilow House, we were open to young people from elsewhere in the country. And the service was set up on the basis that the building that we were working from wasn't really going to be fit to provide the type of services that we needed to be able to offer to young people for very long. And we always knew that we would need to relocate to a more appropriate site once we could put funding in place and develop plans for that. And so we worked really closely with NHS England over the sort of next few years, and by 2020 we'd agreed funding, we had plans in place, and we were all ready to start building work on a new unit at Prospect Park Hospital. But in the summer of 2020, NHS England came and informed us that they'd looked at the need for inpatient beds for CAMHS patients across the South East region as part of their accelerated bed programme. And they were also looking at learning from a programme called the National New Care Models Programme, which was trying to bring CAMHS inpatient care closer to home for young people and coming out with some innovative new ways of thinking about how we could support these young people. And so they told us that they felt they no longer needed us to build a new unit in Berkshire. And what they asked us to do was to think about how we could meet the needs of these young people through alternative models. So if I could have the next slide, please. At the same time, they were transferring responsibility for leading CAMHS inpatient services from NHS England down to Oxford Health, who lead what's called the Provider Collaborative for CAMHS inpatient services across the Thames Valley. And so we were asked to work with both Oxford Health and NHS England to develop a proposal for this new type of model. If I could have my next slide, please. So how did we go about developing a new service model? Well, we did a lot of the things that I think you'd expect us to do. So we looked at the research evidence. There's a lot of learning from the New Care Models programme. So we spoke particularly to Tyne and the Tyne and Wear area of the country, which is the main early implementer of the New Care Models programme. We met with colleagues from Lincolnshire who had had to close their inpatient service at very short notice, and we wanted to understand what they'd done in terms of their creation of a new model. We worked with colleagues from London. We looked at a lot of the research that was being done, particularly South London and the Maudsley Hospital, who were doing quite a lot of really innovative research looking at how alternative outpatient models were effective. We spoke to young people and their families, and I'll tell you a little bit more about what they said, but it was really important that we heard from them. So we looked at what the reports were at national level and what information was coming back through national programmes, but we also did a lot of work with our own service users locally. We undertook a detailed review of the young people that had used our service over the last couple of years. It was particularly important that we went back over a couple of years because, as you've already heard, last year was quite different. And we saw some differences in terms of the need for inpatient care that felt like it was very associated with the pandemic, and we needed to try and ensure that we were really conscious of what need was going to look like moving forward. And we spoke to a lot of other local stakeholders and partners. So we spoke to colleagues in social care, in the local authority early help services, those colleagues that were delivering kind of early help, emotional wellbeing and mental health support as part of the partnership that we have across East and West Berkshire, colleagues in the voluntary sector. We shared all of our proposals with them and we refined it following discussion and feedback from them. So if I can have the next slide, please. So there's a couple of slides that show feedback from young people and families. And it's important to note that the comments are not all specific to Wilow House, but to their experiences of inpatient care in general. But the kind of things that we hear are that the unit's too far away from where people live, and for young people particularly, that means they're separated from their friends, their school, their support networks. The unit was a poorly maintained, crumbling old house. Wilow House isn't, but that's quite a lot of CAMHS units have been built into buildings that weren't designed to be CAMHS units, and they are often not really the kind of environment that teenagers want to be in. And the unit felt like a lock-up place for over-medicated teenagers, and I'm sure you'll have read comments similar to that in the media. And again, that's very associated with the unit rather than the calibre of care that young people are receiving. So if I could have the next slide, please. So they gave us quite a lot of information about what they felt would have been better for them. And what they were saying really was that what they really wanted was support in the community. They wanted to be able to stay at home. They wanted to access the specialist services from the specialist staff that they got from being in an inpatient unit, but they didn't necessarily want to be in an inpatient unit. Specialist education provision was really important. They needed small classes, safe space. They needed people working with them who understood their mental health difficulties, who were trained and who worked closely with their mental health support services. They wanted provision at weekends. They wanted to be able to access support in the evenings as and when they needed it. And they wanted the ability to be able to access support kind of virtually through digital and telephone where possible. And so we've taken all of this on board, but we are also engaging with our service users as we implement the new service and as we refine and develop it. And we actually have a couple of members of staff who are working with our research and development team and doing a formal research project looking specifically at the experiences of, in this particular case, parents and carers and siblings with this new model, because as you'll see in a minute, there is the possibility of impact on families. Most of which we hope will be good, but there are some risks that there may be some difficulties as well, and it's really important that we learn and we tackle those and we make sure that the service is as good as it can be. So if I could have the next slide, please. So how does the new service work? So basically, with our new service, rather than admitting young people into an inpatient unit where they would stay for 24 hours a day, 7 days a week, they will remain at home, but they'll be supported either through a very intensive daycare or home treatment programme or a combination of the two. The service is open 7 days a week and will be open 365 days a year. It's open for different numbers of hours, Monday to Friday and at weekends, and that's quite deliberate because what the other services and what the research that's been done in this area shows is that actually young people need to be with their families, and if the families as well as the young people are given the right support, then actually they can improve and increase the pace at which they recover by having time at home at weekends and having that support from their families. So that's really, really important. The duration of treatment, we expect that most young people will be with us for about 12 weeks, and the intensity of treatment that we offer will vary in accordance with the needs of the individual young person. So our aim is really to stabilise things, to reduce the intensity of need, and to get them back out into community services, into their school, back out to seeing friends in as short a period as possible. And so the intensity that we work with them on will reduce over that 12-week period. So most of them will start coming into us for the full 7 days a week and for the full kind of period, but gradually over time they reduce the frequency with which they're in the service. A couple of other things that are really important about the new service. It's been designed to meet the needs of young people who would otherwise have been admitted to the type of unit that Wilow House was previously, but also to support those who need care for an eating disorder. A lot of our young people who needed treatment for an eating disorder were having to be admitted to an inpatient unit outside of our geographical area. And in fact, for a lot of them, often outside of the Thames Valley, so into units, specialist units in London or Kent. And what the research is showing is that often they then end up staying in these units for quite a long period of time, and the recovery is not as swift or as effective as we would like it to be. And then actually the provision of these intensive services result in better outcomes for children and young people. What we're also able to do with this new service is to support 16 young people at any one point in time, rather than the 9 that we were able to support as inpatients. So we've increased our capacity to look after young people. I can have my next slide, please. So what, few more bits about how the new service works. So there are some things that are very similar to the way that we worked as an inpatient unit. So we still have a multidisciplinary team. So we have psychiatrists, we have nurses, we have psychologists and other psychological therapists, and we have allied health professionals, including a dietitian and an occupational therapist. We've really expanded our therapy team, so we had to recruit a number of new staff, and we are now just over 90% recruited to those new staff, which is a huge achievement in the short period of time. We've had to develop a new programme for eating disorders, and so those young people will receive a therapeutic programme that is fully concordant with the National Institute of Clinical Excellence guidelines, and aligned with our community eating disorders service, so that young people effectively can step up and step back down into community care. We have always had a special school as part of our inpatient unit, and we work really closely with Wokingham Borough Council, who provide that school for us, to ensure that we were able to maintain that provision. So it's a really vital part of our daycare that young people attend school, and that our school staff work really closely with their home school so that they're not missing out on their education as they go through their mental health treatment, and that we're able to remain linked with what they were studying in their home school. And we have a full programme of activity, which is the kind of interventions that we would be providing in an inpatient setting. So psychiatric assessment, medication, monitoring, physical health interventions, psychological and family interventions, individual and group focused interventions. And one of the things that's particularly key and new and exciting about this model is the way that we work with parents and carers. So we are bringing parents and carers into the service and working with them to teach them the same skills that we're teaching their young people, and we're supporting them to be able to then use those skills in the home with their young people. And the feedback that we're getting on that so far is really good. So if I could have my next slide, please. So what about if a young person needs help overnight? Obviously, we would previously have had young people in the unit, so we need to make sure that we've got the right support in for parents and carers. And what we know is that actually if we're supporting people well in preparing, they don't need much support overnight. And that's been borne out with our experience so far. but we've not had any young people presenting needing crisis support or additional support overnight. But we do put a lot of work into preparing for evenings and preparing for weekends, working both with young people and families. And we do have a crisis team that's available and on-call staff who are available overnight with a handover meeting every day so that they're briefed on the young people that are in the daycare programme and are able to support if need be. Next slide, please. I guess the other intuitive question is what happens if a young person does need inpatient care? There are some families that will really struggle to be able to have their young person at home. Some young people whose difficulties are particularly challenging in the evening and overnight. And we do still have a role as access assessors, and we will still identify if a young person needs an inpatient bed, and we will still be able to provide that through our Thames Valley Provider Collaborative. What we believe is that the new service will be able to both reduce the numbers of young people who need inpatient care and reduce the length of that inpatient stay where it is unavoidable. And if I can have my last slide, please. So just a little bit about our journey so far. We closed our inpatient beds on the 30th of April. And the new service went live on the 1st of May very successfully, with all of the young people that we were supporting at the time either being successfully transitioned back to their community service or into the new service. We had planned to have a small number of young people in the service to start with, so we should be up to 8 at a time at this point, and we are. We are anticipating being up to the full 16 by kind of November, December time, and we're on track for that. We worked really closely with our staff team through the change programme, and one of the things that I think is really positive is that those who wanted to come and work in the new service were able to transition. Those who wanted to work in other areas of healthcare, either because they saw this as a good opportunity to move elsewhere or because they perhaps wanted to continue working nights, were supported to do so. So we've retained everybody within appropriate services within the HFT or our partners. We've successfully recruited to more than 90% of new roles, and all of those staff are now in post. We undertook a really significant refurbishment programme through the summer. The service moved to Prospect Park for 6 weeks and then back again just a couple of weeks ago. So we've been able to knock down walls, refurbish and repurpose bedrooms into clinic spaces, and we now have a really welcoming and supportive space. My office is there, and the atmosphere on the unit now is amazing. Actually, it's young people are so pleased to have seen the investment that's been put in to the service that we're providing. We obtained some additional funding from NHS England because we thought we would need more inpatient beds than we normally do as we transition through this to this new service. Last year we had about 20 young people needing admission to inpatient care up to this point in the year. The year before it was about 16. This year we've had 8 young people that we've needed to admit, and we've supported 17 through the new service. So we're absolutely on track in terms of being able to achieve all the benefits that we hoped we would achieve through this service in terms of reducing inpatient admissions and supporting young people closer to home. So very, very excited to be able to share this with you, and I'll hand over to any questions.
Thank you very much, Louise. Really progressive model. I know our partners, our health partners across our Thames Valley Collaborative are really looking to see the impact and whether we can spread this, and intention of spreading new models that support patients, families, carers to live at home and be well supported. Only escalating to inpatient care when it's absolutely needed is really the right way to go. So really well done to you and the team. I've got a question from Nicholas Welch. What is the number of young people that are waiting for this service currently? Also, what is the criteria to be accepted in the programme?
So the criteria to be accepted are the same criteria as the national criteria for CAMHS inpatient care. So they're laid out in a national service spec document. So basically you have to be suffering from an acute mental illness. It has to be a mental illness rather than something that's triggered in relation to kind of drug and alcohol difficulties. There are more specialist units that are available to support young people who need secure care or who need care because they have mental health difficulties comorbid with learning disability and autism. So we don't provide, or death deaf CAMHS, for example, we don't provide those services, although we do support access to those services. So we're very much in line with the national criteria for inpatient admission. In addition to those national criteria, we need young people to be consenting to come in to our service, and we need to be confident that their risks in terms of sort of self-harm and risks associated with suicide can be managed safely while we have them at home overnight. So those are the sort of two criteria that are different to any other inpatient setting.
Can you respond to the question about numbers of young people waiting?
Yeah, we don't yet have a waiting list for young people. So we have actually so far been able to plan admission for all of the referrals that we've had so far that have been deemed suitable.
Louise, thank you very much. That's all the questions. I'm now going to hand back to our chair, Martin Earwicker, to close the AGM. Thank you, Martin.
Please unmute, Martin.
Thank you very much, Alex, and thank you very much to everyone who's joined us today. I hope you found it both interesting and, as I have, inspiring to hear the work of the Trust. And I would like to say, as Chair of the Trust, how proud I am of all the staff of the Trust and the work they're doing and have done during the last year. And in closing, I'd just like to thank everyone in the public for the support you've given us. And if you're interested in joining us as a governor or as a member, please go onto our website where you'll find all the details. Thank you very much.